I'm David Olds, and I'd like to spend a few minutes talking with you about the STAR framework and the program emphasis on grounding your work with families based on the client's heart's desire. Historically, the program itself grew out of work that nurses in Elmira, New York, and I conducted to articulate the key features of the program design. The nurses developed detailed um, outlines of topics that should be covered with individual families uh, during the course of pregnancy, depending on what stage of pregnancy women were at, and throughout the first 2 years of life, depending on mother's adjustment to the postpartum period and how babies were developing. There were no visit by visit guidelines. And in a way, um, this was an advantage because it meant that nurses could adapt the particular content of the visits to individual family needs on a really on a moment to moment basis. But as we replicated the program in Memphis, Tennessee, and then Denver, Colorado, and then more, on a much broader scale, we realized that it was critical that there be visit by visit guidelines that would give nurses guidance about the particular topics that made most sense in addressing the needs of women at particular phases in pregnancy and in the postpartum period in the first 2 years of life. That was a strength, but it was also a challenge because it has become clear that many nurses have interpreted these visit by visit guidelines as the Bible. That these are these visit by visit guidelines need to be adhered to at all costs, and actually, the program is most clinically competent if nurses are making adjustments to content and dosage depending on the risks and strengths that mothers are revealing and families are revealing over the course of nurses' interaction with families. So we eventually went back and developed the STAR framework to give nurses guidance about how to adjust content and dosage to the particular needs of families on a moment to moment basis. The original nurses in Elmira said to me, you know, we cannot visit all families with this standardized visitation schedule. It's just way too much. And my response to that was, well, adjust the visit schedule to the particular needs of families you're serving and make sure that those families at highest risk are getting the full dosage. And it took us maybe 30 years to figure out that we needed to provide better guidance to nurses about how to actually accomplish those adjustments in content and dosage. And that's what you're learning about now with the STAR framework. So we're really grateful to you for taking the time to immerse yourself in the details of the STAR framework because actually it is the program. It's meant to emphasize both client strengths but also their vulnerabilities. And it's critical, we think, that nurses have an appreciation and start with strengths and base all of their work with families on those strengths while keeping in mind and paying attention to the particular vulnerabilities that are being um, disclosed over the course of delivering the program. There is a focus on proximal risks, and the proximal risks are really designed to help nurses understand those factors that will have a direct effect on fetal growth and development, on infant health and development, and the mother's own adaptation to her life in this new phase. Distal risks are those that are more not as proximal, but they create general adversity and make it more difficult for mothers to navigate the challenges of caring well for herself and her child. So I'm really excited, actually, for you to learn about STAR. And I should also say that it's not a final product. As we've rolled out the STAR framework nationally, we've heard from nurses that the framework does not adequately address all risks. And so a subcommittee of the Innovations Advisory Committee is examining those risks in STAR and coming up with an elaborated characterization of risks that are important for you to pay attention to in the conduct of your visits, and additional guidance for nurses to follow in delivering STAR. And the expectation is that that additional elaboration of risks and guidance for nurses will be available in late 2018. In the meantime, it's critical, we think, that nurses begin delivering STAR as it is designed now, and because this adjustment in content and dosage is critical for effective and efficient delivery of the program. Now, I'd also like to talk with you about following your client's heart's desire. And I'd like to start with this by describing a couple of things. One of them is that the program is really grounded in attachment theory. Attachment theory operates on the assumption that we as human beings are wired from an evolutionary perspective to protect our offspring, and especially mothers, of course. And at some level, mothers and fathers' deepest heart's desire is really to protect their babies. Let me just give you an example of this. One young mother served by the program was addicted to tobacco. She drank heavily. She was belligerent to her nurse, and not surprisingly, she revealed that she had been tortured as a child. And she was really resistive to the nurse, but what she ended up saying is, "And I'm afraid that I'm going to do this to my own child." This young mother had all of if you just listened to her, you would be overwhelmed in some ways by her resistiveness and her anger. But the nurse took the time to really listen. And in the course of listening to her, this mother made this revelation that I don't want to do this to my own child. That's heart's desire. And sometimes nurses have, I think that we may not have adequately characterized heart's desire as that primal instinct to protect one's child. And it sometimes has been confused with goal setting. Goal setting grows out of that heart's desire, but the basis of a therapeutic relationship with vulnerable mothers, all mothers, really depends on aligning with that basic heart's desire. So I hope that will provide some clarification as we go forward in delivering the program with the highest levels of clinical excellence. Thank you.